So for those of you who don't know me, I am an adult rheumatologist and a professor of medicine at the University of Toronto. Now, while many of you may not know me personally, you may be familiar with some of my work. I was the architect for the 2013 systemic sclerosis classification criteria. And based on that success, I was asked by the American College of Rheumatology to be the principal investigator or senior investigator for the 2019 EULAR ACR classification criteria for systemic lupus. I then subsequently served on the ACR COVID task force for the management of rheumatic diseases who have COVID infection, and then subsequently the guidelines or recommendations for the use of COVID vaccination. So as a result of that body of work, I have received funding from both the ACR as well as EULAR. Some of that work has been published on an online resource called Up to Date, and I receive royalties for that work as well. In terms of potential conflicts of interest for today's lecture, I have been a trialist for clinical trials sponsored by Bristol Myers Squibb, Roche, and Boehringer, most notably evaluating the efficacy of tocilizumab and of nintedanib in systemic sclerosis-associated interstitial lung disease. I will be referencing that data in the ACR guidelines. But in terms of steps that I've taken to review and mitigate my potential conflicts of interest, I gave up all relationships with the pharmaceutical industry 1 year prior to becoming the principal investigator for the ILD guidelines. And I will continue to give up all pharmaceutical relationships as long as I am the principal investigator for updates to this guideline. So the objectives. During the session, I hope to achieve 3 objectives. The first is that I'll explain the ACR guideline development process and its impact on recommendations. And the reason why I say that is since the ACR guidelines have been published, other major organizations have published guidelines in the same space. But what you will find is there are some discrepancies between the guidelines, and that's partly related to the methods that were used to develop the guidelines. Secondly, I will share with you the evidence-based clinical practice guidelines that are meant for clinicians who care for people with the systemic autoimmune rheumatic diseases who are at risk for or have developed interstitial lung disease. And so it's phrased this way because these guidelines are not meant just for rheumatologists. Rather, they were co-developed with pulmonologists, as they're called in the United States, or respirologists, and it has been endorsed by the American College of Chest Physicians as well. And then finally, I will highlight the ACR recommendations for the use of vaccinations in people with systemic autoimmune rheumatic diseases and interstitial lung disease, and the concomitant use of immunosuppressive therapies during the vaccination period. So the first clinical pearl is that in the title and in my objectives, you may have noticed that I use the term systemic autoimmune rheumatic disease, or SARD. And so this is a new nomenclature. You may be more familiar with the term CTD, or connective tissue disease, and that's an older term that you will see in our old textbooks. But both EULAR and ACR are moving away from the term CTD because CTD typically includes other diseases that are truly problems of the connective tissue, such as Ehlers-Danlos syndrome. But that is not really the predominant disease that we as rheumatologists care for. What we really care for are the systemic autoimmune rheumatic diseases, and hence the change in nomenclature. Now, to speak a little bit about guidelines. The primary purpose of a clinical practice guideline is to provide guidance to healthcare professionals. The type of treatment a patient receives should not depend on what part of the country they live in, but rather all specialists should be treating patients in a relatively comparable manner. However, there are other objectives of the clinical practice guideline. And the second is to reduce the geographic practice variation that I just alluded to. But more importantly, clinical practice guidelines from major organizations can be used for advocacy and awareness. Often, the tests that are recommended or the medications that are recommended are not covered by the private insurer or the government, the governmental agency, whoever is paying for these things in your jurisdiction. And so often, a clinical practice guideline can be taken to the government or to an insurance company to advocate for coverage or access to care. So here's an example where I have been involved with the lobbying of the government in my province. So in Canada, the coverage of medications and access to care is a provincial jurisdiction, not a national jurisdiction. So we need to lobby each of our provincial governments. In my case, I work with Scleroderma Canada. That is a patient organization. And what, in my experience, physicians are terrible advocate lobbyists. Rather, the patient's voice has a stronger sway with the government. And so often our lobbying efforts are led by the patient organization. So in this case, Scleroderma Canada. As you can see, I'm in the picture standing next to the two advocates from Scleroderma Canada. As I mentioned, the most effective voice is the patient. So that's the Black woman with the curly hair. And you can see she's wearing her oxygen with nasal prongs at the governmental visit. And next to her is the pulmonologist that I work with as well. Lobbying is a team effort. And so, while I'm not as familiar with the mechanisms of access to care in Sri Lanka, I would suggest that if access to care is an issue, the clinical practice guidelines may be one document that you take with you to help lobby for access to care. So now in terms of the development of the guidelines, the American College of Rheumatology uses the GRADE methodology. This was developed by Gordon Guyatt at McMaster University. And first, that these guidelines are all evidence-based. All forms of published evidence are considered. However, we know that not all evidence is of equal quality. And so when we evaluate the published evidence, we have to rate the quality of the evidence. That is the certainty of evidence. How much certainty do we have around point estimates generated from that clinical trial or observational study? We know that clinical trials are the highest form of study design that are least susceptible to biases that threaten the validity of an estimated treatment effect. However, in many cases, particularly in rare diseases, we have observational studies, case reports, case series. And so that is still evidence, but it is rated of very low or low certainty. Now, there are other factors that can downweight evidence. So you may start with a clinical trial. However, it would be downgraded in its certainty if there are limitations in the study design, that is, there are high risks of bias, there's inconsistency of results across studies, the indirectness of evidence. So while we have a few clinical trials in systemic sclerosis-associated ILD, we have no clinical trials in Sjogren's-associated ILD and few studies in myositis-associated ILD. So we use the evidence from systemic sclerosis and indirectly make inferences about it in the other diseases. If there's imprecision around the estimates, or if there's publication bias. And so what you will find is that despite the fact that we now have a few clinical trials in rheumatology evaluating novel treatments in systemic sclerosis-associated ILD, those clinical trials are downweighted as low or very low quality certainty evidence due to the issues that I've outlined here. A second point that I'd like to make about rheumatology clinical trials is that our trials tend to be very small. So I've summarized in this table 4 of the clinical trials that evaluate efficacy of treatments in interstitial lung disease: Scleroderma Lung Study 1, Scleroderma Lung Study 2, the Census trial, and Trail 1. And so if you look at the sample sizes of our clinical trials, they're in the hundreds of patients. 158, 150, 142, 576 was a very large trial for us. But if you compare to the cardiology clinical trials, they have tens of thousands of patients in a single study. ALLHAT had 33,000 patients. Jupiter had 17,000 patients. Twilight had 9,000 patients. And what that means is that in rheumatology, we can have less certainty around our estimates of treatment effect due to our low sample sizes alone. A second issue when it comes to using this evidence to inform guidelines is the use of primary outcomes. All of the scleroderma ILD trials love to use forced vital capacity as the primary outcome. This is the outcome that pulmonologists love to use clinically, rheumatologists love to use this clinically when we evaluate ILD. However, that is a surrogate outcome. It is not an outcome that patients care about. And the biggest drug regulatory agency in the world is the US Food and Drug Administration. And when a drug is developed in a clinical trial and the drug company wants to get the indication in that country, the first market they want to go to is the US FDA, because they know that if the US FDA approves the medication, it is most likely the other markets will follow suit. Whereas if the US FDA does not approve a medication, it becomes less likely that other jurisdictions like EMA, like the Japanese Health Authority, will endorse these medications as well. And so the US FDA prioritizes primary outcomes that are most relevant to patients. Patients care about how they feel, will they live longer, and how they function. And so according to the US FDA, FVC does not fulfill any of those three mandates that patients care about. So according to the FDA and the other drug regulators, the FVC is a surrogate outcome for all the things that patients care about. And as a result, that further downgrades the certainty of the evidence that we have when we present the evidence to the drug regulators. So the consequence, even in a well-designed clinical trial, the certainty of evidence can be low or very low. As you can imagine, the principal investigators of these major trials are not happy with the guidelines when we're told that the $2 or $3 million US they spent on their trial is now considered low or very low evidence. So when we develop the guideline, we have a systematic review of the literature, we have an evaluation of the quality of the literature, the certainty of the evidence. Separately, we have an expert voting panel. These are experts in the field. In the case of this guideline, there were rheumatologists and pulmonologists who have expertise in interstitial lung disease in the setting of the systemic autoimmune rheumatic diseases. Each recommendation is presented as a statement, and the voting panel will review the evidence, and then they cast a vote, either for or against the recommendation and for the strength of the recommendation. And 70% agreement on both the direction and the strength is required for there to be consensus. And so we have four possible outcomes. A recommendation could be strongly for or conditionally for, or strongly against or conditionally against. And these are depicted in our figures as colors, as green and red. Now the ACR is transparent about instances where the voting panel could not achieve consensus. And I will come to that when I present the guidelines. The third aspect of the guidelines, and one that I'm particularly proud of, is the inclusion of patients. It is now considered a requirement to include in patients right from the beginning in terms of inception and development of any kind of research project. And so I'm proud to say that this guideline included the largest patient panel of any guideline in rheumatology. Now, the reason why this is important is that in a setting where we have low certainty evidence and a small body of evidence in which to, I'm sorry, my slides are running away, where we have a small body of evidence to base our guidelines, these guidelines become particularly sensitive to patients' preferences and values. And so these were incorporated in the guideline. And so I'm just going to take a moment to communicate to you some of the messages that the patient panel told us that they want their physicians to know. Number one relates to communication. And here's a quote from one of the patient panelists. "My doctor helps me see the big picture of how I could benefit from the medicine, what we are trying to avoid longer term." Patients want us to explain why we're doing what we're doing, why we're recommending the tests and the treatments that we are. The patients also want to hear from us what are the goals of treatment, because their goals of treatment are often different than our goals of treatment. And so here's one quote from a patient. "My goal was to survive, then achieve small life goals with my children, go back to work, talk without choking, and to be able to smell flowers again." You know, these are not the kinds of goals we think about when we write prescriptions. So I share this to help remind you, what are our patients thinking? They also want us to speak about the side effects of therapy, and they want to be able to inform the decision-making. They don't want us to choose the medications for them based on the side effects we think they don't want. And so here's an example quote. "It depends on how sick I am and how badly I need to manage my disease symptoms." And so, although I'm Canadian, nearly everybody involved with this guideline was American. And one slight cultural difference I found is that the American rheumatologists are very afraid of cyclophosphamide. They are particularly afraid of infertility in a young woman when given cyclophosphamide. Whereas in Canada anyway, any rheumatologist or pulmonologist that's over the age of 50, that was one of the few drugs that we had when we started practice. And we've come to learn that cyclophosphamide is actually a very good drug. And what the patients, the young female patients told us, is they want to know what their options are. They want to know if cyclophosphamide is an option for them. They don't want the doctor to say you can't have cyclophosphamide because of infertility. They want to decide. Often, if their life is at risk, they are willing to accept the side effect of infertility if it means that cyclophosphamide may save or prolong their life. Finally, the fourth area is screening and monitoring. Patients want to be screened. One patient said, with autoimmune diseases, things just come up. And sometimes you don't even think to mention it as a patient. So screening can be important, even just on history, to catch things that may otherwise be overlooked. Another patient said, I thought shortness of breath was just fear and dermatomyositis. Early detection was key and important. And so I'd like to highlight for you that clinical practice guidelines, unlike classification criteria, are not international in scope. I am honored and humbled to be here today to merely share the guidelines with you. Neither I nor the American College of Rheumatology or American College of Chest Physicians are in a position to tell clinicians in Sri Lanka how to practice medicine. In the setting of low certainty evidence, the guidelines in Sri Lanka will also be very sensitive to the values and preferences of the patients in Sri Lanka. The way patients value efficacy and safety in Sri Lanka may be very different than the way patients in the United States or in Canada value the safety and efficacy of a medication. Recommendations may also be sensitive to the culture of the region and may be sensitive to the cost of medications in the region, as well as access to care. Now, one approach that a major organization like the College of Specialists in Rheumatology and Rehabilitation may consider is developing your own clinical practice guidelines. The downside of that, though, is to develop a rigorous guideline costs a lot of money and takes a lot of time. And so if that is not a place where the college may want to spend a lot of its resources, another approach is what they call the adolpment of a guideline. And so I present that to you as as an example of what the Saudi Society of Rheumatology did for the American College of Rheumatology guidelines for the treatment of rheumatoid arthritis. They used the ACR guideline as a starting point and then went through each of the recommendations with a voting panel based on the experts from that region, and they re-vote on the recommendations. And in that way, many of the guidelines may end up being the same, but there may be some guidelines that are slightly different based on patient preference and values, culture of the region, cost, and access to care. So I share this with you and with the leadership of your college as an idea. Okay, so now that's guideline development process. So now let's shift gears to objective number 2, the guidelines themselves. There are 5 groupings of recommendations in this guideline. The first represents who should be screened. This guideline covers 5 rheumatic diseases: rheumatoid arthritis, systemic sclerosis, the idiopathic inflammatory myositis, mixed connective tissue disease, Sjogren's disease. We know that they all confer an increased risk of interstitial lung disease compared to the general population. However, we also know that the risk of developing ILD and ILD progression varies across these diseases and within each of these diseases. So in the guideline document, we present a table of published risk factors for the development of ILD across each of these diseases. So in the setting of systemic sclerosis, we know that the SCL70 antibody, ANA with nuclear pattern, diffuse subtype, male sex, Black race, early diffuse disease, that is in the first 5 to 7 years of onset, and elevated ESR and CRP all confer an increased risk of ILD. In the setting of rheumatoid arthritis, it has been published that a high titer rheumatoid factor, an anti-CCP antibody, a history of smoking, older age of rheumatoid arthritis onset, and high rheumatoid arthritis disease activity, male sex, and higher body mass index all confer an increased risk of ILD. In the setting of the idiopathic inflammatory myopathies, the advanced scleroderma-specific autoantibodies confer increased risk. The anti-MDA5 antibody confers an increased risk of rapidly progressive interstitial lung disease, as well as mechanics hands, arthritis or arthralgia, and ulcerating cutaneous lesions confer an increased risk of ILD. When it comes to mixed connective tissue disease, the presence of dysphagia, Raynaud phenomenon, and other systemic sclerosis clinical manifestations increase the risk of ILD. And finally, Sjogren's disease. We know that the Ro52 antibody, ANA, Raynaud phenomenon, older age of Sjogren's disease diagnosis, and lymphopenia confer an increased risk of ILD. So this table is in the published document. This is not meant to dictate who should be screened, but rather indicate to you who is at increased risk of ILD. If you don't have access to the table or you don't remember, the ACR takes a position that we should, if you're uncertain, then go ahead and screen. Okay, so now for the screening algorithm. If a patient with a systemic autoimmune rheumatic disease has an increased risk of developing ILD, the guidelines conditionally recommend screening with pulmonary function tests, that is with spirometry, lung volumes, and diffusion capacity, as well as high-resolution CT chest. So clinical pearl here, the pulmonary function test is not spirometry alone. Many pulmonologists will do office spirometry when they monitor their patients, but the college, as well as the American College of Chest Physicians, take the position that office spirometry is insufficient for screening of ILD. Rather, we also need lung volumes and diffusion capacity. Second clinical pearl. Sometimes if a rheumatology patient presents to the emergency room with acute onset shortness of breath, the emergency room physician is concerned about a pulmonary emboli. And so often these patients will have a VQ scan or a CT angiogram, but this is insufficient for the screening of ILD because a CT angiogram is performed at incomplete inspiration to maximize pulmonary artery enhancement. And this can produce atelectasis that can obscure or mimic the ILD. And so a CTA is insufficient for the screening of ILD. So this is the two screening tests, pulmonary function test and high resolution CT scan. The guidelines conditionally recommend against a number of tests for the screening of ILD. The guidelines recommend against the use of a plain chest x-ray, a 6-minute walk test, ambulatory desaturation testing, or bronchoscopy as screening tests. It strongly recommends against surgical lung biopsy for the screening of ILD. However, it is recognized that many of these tests may be required if you're trying to rule out another diagnostic entity. Ambulatory desaturation testing may be required if a patient, particularly a scleroderma patient, has difficulty doing pulmonary function tests because they cannot achieve a tight oral seal around the mouthpiece. Bronchoscopy may be required to rule out infection, sarcoidosis, lymphoma, or alveolar hemorrhage. And finally, a surgical lung biopsy may be required in rare circumstances where you're trying to rule out malignancy. In terms of monitoring tests, the guidelines conditionally recommend against chest radiographs, 6-minute walk test instance, and bronchoscopy for the monitoring of patients. However, again, there may be specific circumstances where these tests may be required to rule out, say, infection or alveolar hemorrhage. Now, in terms of the monitoring of ILD, once ILD is diagnosed, there are 3 tests that are conditionally recommended. The first is pulmonary function testing, again with spirometry, lung volumes, and diffusion capacity. Now, there is a suggested frequency. This is not based on evidence, nor is it based on the expert voting panels. It is based on the voting panel's suggestions. They recommend that for the idiopathic inflammatory myopathies to do PFTs every 3 to 6 months in the first year, and then less frequently once stable. For systemic sclerosis, every 3 to 6 months in the first year, and then less frequently when stable. And for the other diseases, rheumatoid arthritis, Sjogren's disease, mixed connective tissue disease, it is suggested to do pulmonary function testing every 3 to 12 months in the first year, and then less frequently once stable. It is also conditionally recommended to do ambulatory desaturation testing every 3 to 12 months. Now, this is a test that it is not within the scope of a rheumatologist. We do not do this kind of testing, where it is more typically within the scope of a pulmonologist. And so this is where we advocate for co-management of these patients. And finally, it is conditionally recommended that we monitor ILD with high-resolution CT chest as needed. It does not need to be done every 6 to 12 months if the patient is clinically stable. The third grouping of recommendations in the guideline relates to first-line treatment of ILD. Now, these are presented as a grouping across each of the diseases and listed in a preferential order. The first grouping is preferred, that is expected to be most commonly prescribed, whereas additional therapies may be used in certain situations. Now, there are many situations that may lead a provider to choose a different option for the ILD treatment. For example, the presence of comorbidities or extrapulmonary disease activity. So in the guideline, each of the 5 diseases are listed across the top, and you can see a box that outlines the menu of treatment options. Across all 5 of the diseases, the recommended first preferred ILD treatment is mycophenolate. However, as you can see, there may be other reasons why someone may choose another medication. So let's take the example of rheumatoid arthritis. If a patient with rheumatoid arthritis has both ILD and active inflammatory polyarthritis, in this situation, perhaps rituximab is the best first ILD treatment. The guidelines make a strong recommendation against the use of glucocorticoids for the treatment of ILD in the setting of systemic sclerosis. And this is due to the risk of scleroderma renal crisis. We know that scleroderma renal crisis is the abrupt onset of accelerated hypertension, acute kidney injury, and microangiopathic hemolytic anemia. We believe that the mechanism is the result of vascular injury and endothelial dysfunction induced by glucocorticoids. And this leads to renin-angiotensin system activation, as well as precipitating renal vasospasm and renal ischemia. Now, using clinical cohort data, we know that glucocorticoids increase the risk of scleroderma renal crisis 4 to 5 times at prednisone doses more than 15 milligrams a day. So in those with systemic sclerosis, we try to avoid glucocorticoids altogether, but in rare circumstances where glucocorticoids are needed, we try to restrict our doses to less than 15 milligrams a day. There's one observational cohort study that suggests that for every 1 milligram of prednisone, the risk of death in a scleroderma patient increases by 4%. Then, now before I go to the next grouping, let me further speak about treatment options for first-line treatment of ILD and myositis. This may include not only mycophenolate, but also azathioprine, rituximab, calcineurin inhibitors, JAK inhibitors, cyclophosphamide, and in these patients, you may consider short-term glucocorticoids. In patients that have mixed connective tissue disease that are not scleroderma predominant, but perhaps lupus predominant, their guidelines recommend the use of mycophenolate, azathioprine, rituximab, tocilizumab, or cyclophosphamide. In those with rheumatoid arthritis, first-line ILD treatments include mycophenolate, azathioprine, rituximab, and cyclophosphamide. And similarly, in those with Sjogren's disease-associated ILD, treatment options include mycophenolate, azathioprine, rituximab, and cyclophosphamide. So the next grouping of recommendations is how do we treat the progression of ILD if the ILD has progressed despite first ILD treatment? For the purpose of guidelines, the progression was defined using the INBUILD criteria. That is a relative decline in forced vital capacity of at least 10% of the predicted value, or a relative decline in FVC of 5 to 10%, and a worsening in respiratory symptoms, or an increased extent of fibrosis on high-resolution CT chest, or a worsening of respiratory symptoms and an increased extent of fibrosis on CT chest, all within 24 months. The guidelines do not mandate that you use this definition as progression. We just needed a standardized definition for the expert panel to deliberate on when considering medication options. So again, the guideline presents a menu of options presented across diseases. If mycophenolate was not the first ILD treatment, well then in this case, mycophenolate is recommended as the next treatment that should be used. In patients with systemic sclerosis, one may consider adding or switching to rituximab, nintedanib, tocilizumab, or cyclophosphamide. Similarly, in those with myositis, one may consider rituximab, nintedanib, or cyclophosphamide. For those with mixed connective tissue disease, one may consider rituximab, nintedanib, tocilizumab, or cyclophosphamide. In those with rheumatoid arthritis, similar treatment options, rituximab, nintedanib, tocilizumab, and cyclophosphamide. And finally, in those with Sjogren's, you could consider rituximab, nintedanib, and cyclophosphamide. Now, in systemic sclerosis, one may also consider referral for consideration of autologous hematopoietic stem cell transplant at an experienced center, if that's available. There is, again, a strong recommendation against the use of glucocorticoids in those with systemic sclerosis due to the concern of scleroderma renal crisis. Whereas for the progression of ILD across the other 4 diseases, there is a conditional recommendation against long-term glucocorticoids in these patients. And finally, there's a conditional recommendation for referral for lung transplantation at an appropriate time if it's available. The 5th and final grouping of recommendations in the guideline relates to an entity called rapidly progressive ILD. This is a relatively new entity of the modern era. This is a recognized subpopulation of those with interstitial lung disease, characterized by a rapid progression of requiring no oxygen or minimal baseline oxygen to requiring high oxygen requirements or even intubation within the order of days to weeks. The normal natural history of ILD across the rheumatic diseases is a slow progression over months to years. So if you see someone progressing in the order of days to weeks and requiring high levels of oxygen without a documented alternative cause, such as infection or heart failure, one should invoke the diagnosis of rapidly progressive ILD. Now, in rheumatology, this is most typically associated with the anti-MDA5 antibody, typically seen in those with the inflammatory myositis or the anti-synthetase syndromes. The issue for the clinician is that you are often asked to consult on these patients when they're already admitted to the ICU. They're already intubated, they're ventilated, they're probably on pressors. And so, of course, you will do a good history and physical exam. And if you have access to advanced autoantibody testing, you may request the antibodies. But even in the most sophisticated high-resource centers, these antibodies take weeks to return. It might be 2 or 3 weeks before you get the result, but yet you need to make a therapeutic decision within 24 hours. And so purposely, the guideline has this triangle, the diamond shape underneath rapidly progressive ILD, where it says in people with severe disease or a high suspicion for the anti-MDA5 antibody. You're still waiting for the results, or you may not have access to this antibody testing. But if you have a high suspicion for rapidly progressive ILD that's in the setting of such a patient, the guidelines conditionally recommend combination triple therapy. That is IV glucocorticoids, usually pulse steroids, 500 to 1,000 milligrams of solumedrol, with 2 additional therapies. Now, traditionally, in most centers, the additional therapies might be cyclophosphamide or mycophenolate, or if you have access to rituximab. However, here is the one example where the guidelines are recommending something where practice is evolving in the United States in advance of the evidence. Most high-volume centers in the United States would preferentially use combination glucocorticoids with IVIG and a calcineurin inhibitor, such as tacrolimus. And so for this reason, the American pulmonologists strongly advocated for combination IVIG and tacrolimus in the treatment of these patients. They are particularly concerned about the risk of sepsis in such a rheumatology patient treated with cyclophosphamide or rituximab, because once these medications are given, it's very difficult to reverse that. And if these patients live more than 1 or 2, 3 weeks in the ICU, they're at very high risk of sepsis. So as you can see, this guideline is very large. 5 diseases that look at screening, monitoring, first-line treatment, progressive treatment, and rapidly progressive ILD. This guideline has more than 260 recommendations. Despite that, there are still other questions that practicing clinicians have. And so while we could not tackle every question, we do provide additional resources in the guideline document. The first additional resource is this table number 3, where we summarize all of the recommended medications, their indications, but most importantly, how to prescribe the medications and how to monitor those medications. And so there may be some medications that some clinicians are not familiar with, such as tacrolimus. So this may be a nice resource if you're not familiar with how to prescribe and monitor tacrolimus. There are other interventions that have been suggested that one can consider. First grouping is the non-pharmacologic interventions. If possible, it's suggested that we counsel our patients on exercise, aerobic exercise, resistance training, yoga, Tai Chi, because we know that exercise is medicine for the lungs. We may need to consider palliative care. Initially, we refer to palliative care for symptom treatment, that is cough treatment, pain management, air hunger management, but in the long term, it may be required for end-of-life planning. It is also suggested that we consider physiotherapy and pulmonary rehabilitation, things such as chest physiotherapy, incentive spirometry, airway clearance, cardiopulmonary rehabilitation, if available. And finally, within the domain of pulmonologists is the evaluation for supplemental oxygen. There are some additional pharmacologic therapies that one should consider counseling the patient on. One is gastroesophageal reflux management. Many of these patients will have nocturnal aspiration when they lie supine at night. And so we should consider the use of proton pump inhibitors or H2 blockers. The pulmonologists are quite concerned about PJP prophylaxis and pneumonia in our patients. And so they advocate for prophylactic treatment with trimethoprim sulfa. Interestingly, the rheumatologists are not so concerned. We regularly pulse steroids and use cyclophosphamide and biologics, and we don't really see PJP pneumonia, with the exception of those with an ANCA-associated vasculitis. So this may be a cultural difference between the two specialties. Some may consider pro-motility agents, such as domperidone. And then finally, the American College of Rheumatology recommends vaccinations: measles, mumps, rubella, influenza, COVID-19, pneumococcus, zoster, and RSV. And so that brings me to the third objective of today's session, to talk about the use of vaccination or the recommendation of vaccinations in patients with systemic autoimmune rheumatic diseases and interstitial lung disease and who are on immunosuppressive therapy. We know there is a complex interplay between the disease, the risk of infection, vaccinations, immunosuppression, and immunogenicity. And here I'll try to explain this picture. We know that systemic autoimmune rheumatic diseases independently confer an increased risk of infection. When we add immunosuppressive therapy, that adds another element of increased risk for infection. One way of reducing the risk of infection is with vaccines. However, vaccines have an associated risk of causing disease flare. Furthermore, immunosuppressive therapies can reduce the immunogenicity of the vaccine if a vaccine is given while a patient is on an immunosuppressive therapy. So how do we manage all of these competing risks? Well, the American College of Rheumatology has the 2022 guideline for the vaccination of patients with the rheumatic and musculoskeletal diseases. And when it comes to the influenza vaccine and rituximab, they suggest, and it's in the small print below the table, give the influenza vaccine on schedule, but then delay any subsequent rituximab dosing for at least 2 weeks after the influenza vaccine if disease activity allows. With regard to all of our other immunosuppressive drugs, other than methotrexate and rituximab, the recommendation is to continue the immunosuppressive medication. Now, when it comes to the COVID-19 vaccination and IV cyclophosphamide, it is recommended that we time cyclophosphamide administration so that it'll occur 1 week after each vaccination dose when feasible. When it comes to rituximab, it's recommended that you discuss the optimal timing with your rheumatology provider. Often rituximab is given because the patients are very sick, and so we don't want to delay therapy in that situation. Now, when it comes to the live attenuated viruses, the ones that the college recommends vaccination for are listed here: measles, mumps, rubella, varicella, rotavirus, yellow fever, smallpox, influenza nasal spray, and oral typhoid. But when I looked at guidelines in Sri Lanka, it seems to me that there is a recommendation for the Japanese encephalitis virus as well in this region, which is a live attenuated virus. So if you have a patient receiving a vaccination with a live attenuated virus, the American College of Rheumatology recommends holding almost all of our immunosuppressive therapies. It recommends holding our therapies for at least 4 weeks or 1 dosing interval, depending on the medication, before the live attenuated virus vaccination administration, as well as holding the medications for 4 weeks after the live attenuated virus administration. All of these tables are freely available in the guideline document. So what have we learned? Well, hopefully you've learned a little bit about the guideline development process and its impact on recommendations and why the recommendations in one guideline might be a little bit different than another guideline from a major institution. I've presented for you the evidence-based clinical practice guidelines for clinicians who care for patients with systemic autoimmune rheumatic diseases who are at risk for and or have been diagnosed with interstitial lung disease. And finally, I've shared with you that the ACR recommends vaccinations for people with systemic autoimmune rheumatic diseases associated interstitial lung disease, but also provides guidance on what we should do with the immunosuppressive medications before and after vaccinations. The guidelines I've presented to you provide a risk-based approach to the screening and monitoring of interstitial lung disease in people with systemic autoimmune rheumatic diseases. This is one of the criticisms of the guidelines because the clinician has to think a little bit because it's very much catered to the risk profile of the patient in front of you. However, one of the benefits of this guideline, I believe, is that we provide a range of options, that is a menu of treatment options based on the patient profile as well as access to care in your region. These guidelines are based on the best available published evidence, expert experience, as well as patients' preferences and values. I'd like to express a thank you to all of the rheumatologists and pulmonologists. I understand there are some pulmonologists in attendance today, so I've highlighted for you in red the pulmonologists that were involved in this guideline, as well as the patients' organizations. And I've listed them in the corner there: Global Healthy Living Foundation, the National Scleroderma Foundation, Myositis Support and Understanding. That concludes my presentation. Thank you for your attention. I'd be happy to take your questions.
Good morning, everybody. I'm Chandima Abeysinghe, a consultant radiologist at Teaching Hospital Peradeniya. And during the next 15 minutes or so, I will talk to you about how HRCT is such an important tool in diagnosing and assessment of interstitial lung diseases related to rheumatological conditions, and also some of the pathological processes that manifest in HRCT and how they are evolved. So as we heard in Dr. Johnson's lecture just now, HRCT is now considered a very important tool in early diagnosis and then assessing of progression of interstitial lung disease related to rheumatological conditions. How I will talk a few technical points on why it is such an important tool. How HRCT differs from conventional CT is one main point is that it uses some specific parameters to increase the resolution between tissues. We use very thin slices as compared to conventional CT, so that the resolution between the different tissues is enhanced. And also there's a specific algorithm in the machine called the bone algorithm, which will sharpen the edges. So fine detail of the interstitium and pulmonary parenchyma will be enhanced. We don't use contrast in HRCT because we use the natural contrast between specific tissues. Also, I must mention that HRCT uses a very low dose compared to conventional CT, because standard CT, because it's something like 0.2 to 1 millisievert, where standard CT would deliver something like 6 to 7 millisievert per study. Even if we do inspiratory and expiratory studies in one setting, we still use a lower radiation, which is very important because we have to sometimes follow these patients up. And the main variants that we use in the protocol would be the deep inspiratory film, inspiratory series, like Dr. Johnson mentioned. We have to have it in very deep inspiration to avoid spurious interpretation as fibrosis or septal thickening. And then we have to do a full expiratory scan because air trapping, it may not be, sometimes it may be relevant to rheumatological disease as well, but air trapping is more seen only in the expiratory scan, not only, but enhanced in the expiratory scan. Then sometimes we do prone position, especially if we want to differentiate true septal thickening from dependent septal thickening or dependent ground glass, especially in conditions like heart failure. There might be some dependent atelectasis to avoid that confusion, or if you are diagnosing intracavitary bodies, which is sometimes in other conditions, but for those we use prone position imaging as well. Clinically, the utility of HRCT would be in early detection, like Dr. Johnson mentioned. Now there seems to be very little place for chest X-ray, and because in many settings, even though the chest X-rays are normal, we still see changes in HRCT in these patients. Also, if a biopsy is being done, it may not be very relevant to rheumatology, but sometimes when guiding biopsies also, HRCT is useful. Then also, like all of you know, tracking how to assess disease progression and all, just like the fibrosis score and everything, to predict outcomes and monitoring response to treatment, it is very useful. So in order to understand how these HRCT manifestations occur, I think it's good to know about this basic anatomy of the lung, where the functional unit, smallest functional unit of the lung, which can be seen in HRCT, is a secondary pulmonary lobule. If I take you to anatomy days, it's a 1 to 2 centimeter kind of a structure, which is a polyhedral shaped structure. If you think of a polygon in 3D, that is the shape of a secondary pulmonary lobule, which is the smallest unit you will be seeing in an HRCT. No, you don't always see it, but when it's pathological, you can see it. So, talking about this secondary pulmonary lobule again, you would divide it into kind of 3 areas. The central core, or the central lobule area, where the deoxygenated blood is going in with via the pulmonary arterial branch, and then the bronchioles are entering the pulmonary lobule. So it's the lobular bronchiole which branches into the terminal bronchiole, and then it enters this as respiratory bronchioles, alveolar ducts, and then the acini. Finally, the alveoli acini, where the gas exchange occurs. So the second part of the pulmonary lobule, secondary pulmonary lobule, is the parenchyma, which is consisted of the alveoli, where the gas exchange happens. And then you get that when I talked about the polygon, you have the walls of the polygon. They are made up mainly of fibrous walls. And within these fibrous walls, only you get the veins and the lymphatics traveling. So anything that is causing thickening of these fibrous walls, like fibrous thickening or venous congestion or lymphatic congestion or lymphatic infiltrates, anything can cause thickening of these septae. So this is a schematic representation where you get those polyhedrals and the central lobular bronchus and artery entering, and the parenchyma made up of acini, and the walls of the pulmonary lobule made up of the fibrous septa containing the veins as well. Another close-up view of the same. So this is how we see it at the HRCT. This is schematic representation as in an axial section, where you get the septae of the pulmonary lobule and the vessels entering it, the arterial branch and the bronchus entering it, also the veins and the lymphatics going along the walls. And I want you to remember that the lymphatic supply is very rich towards the pleural surface. So this here is a normal HRCT. I'm sure all of you are very conversant with this. So I just want you to remember a few things. In the normal HRCT, we usually do not see these secondary pulmonary lobules highlighted. Especially now, we are looking mainly towards the periphery of the lung because it's the area mainly concerning the rheumatologists. So here we do not see the secondary outlines of the secondary pulmonary lobules. We see the fissures, Also, just remember that the bronchi, the smaller bronchi, stop somewhere between like the junction between the outer one third and the middle one third. You do not see the bronchi beyond that point. Right. So I just want to go through a few HRCT patterns. Mainly the patterns related to the rheumatological diseases would be the reticular pattern, which entails septal thickening and honeycombing. And then you all see a lot of ground glass opacity. That is the high attenuating patterns where you see ground glass opacity and consultations. Nodular patterns we commonly see in other conditions, but maybe you will see in rheumatological conditions like rheumatoid as well. Then hypoattenuation is happening when there is emphysema or air trapping. And mosaic attenuation is just a mixture of both, where you get alternating high and low dense areas in the lung. Most of the time, one is abnormal. And you have the green bud opacities when you get endobronchially spreading diseases. So just talking about elaborating on the reticular pattern, if you remember our previous slide where I showed you that there is no markings in the periphery, no highlighting of the septate of the secondary pulmonary lobules in the periphery. If you look at this carefully, you can see that there is septal thickening, but the secondary pulmonary lobules are not contracted. They are of normal size, but the septae are highlighted. So that means there's something happening, some infiltration is there in those walls of the secondary pulmonary lobule, which may be fluid, which may be tumor deposits, fibrosis, anything can be there. And this is same thing, a subtle change in another patient. Then honeycombing is the most common pattern we see in UIP. It's like the hallmark of UIP, where you get the secondary pulmonary lobules have thick wall thickening as well as they are contracted. So and the parenchyma of the secondary pulmonary lobule becomes less dense. So you have cystic spaces, thick wall cystic spaces which are clustered in the periphery, in the subpleural region mainly, because this is where UIP attacks first. And you see an appearance similar to the honeycombs. And if you look carefully, you can see the bronchus that is dilated in this area. What happens is when the honeycombing occurs, there's fibrosis, so there's volume loss. So with this volume loss drags the bronchus outwards, and it's kind of an ex vacuo dilatation. So you get traction bronchiectasis. Then I told you that in the immediate subpleural region, the lymphatic supply is very rich, and these lymphatics tend to remove the debris and exudates, cellular infiltrates are cleared easily. So because of that only, you get that immediate subpleural sparing. So I hope you will agree, because when we radiologists always think NSIP is that thing that has a more inflammatory X-rate and inflammation going on. Probably now I think you will differ in opinion, but anyway, because of that, the explanation we are taking is that this clearance of debris causes this immediate subpleural sparing. So this is definitely pointing towards NSIP. We do not see this in UIP because UIP causes the fibrosis in the subpleural area. So it's mainly a disease of the subpleural area. We do not see this immediate subpleural sparing. If you all can see this, because this is a very good to remember kind of a thing when you're looking at a HRCT. We can see this not only in NSIP, we see this in COVID infections also, but this is because of that, it's said to be because of that lymphatic clearance. Then another, I thought I'd talk about the entities commonly related to rheumatological diseases first. So this is what we call ground glass. Now we have to remember, when we say ground glass, it is the increasing density of the lung parenchyma or the secondary pulmonary lobule without obscuring the vessels. So if you have ground glass, through that you can still see the vessels. If you can't see the vessels, then you call it consolidation. So this is the early consolidation can present like ground glass, because what can be happening there is either there is something secreting into the alveoli, some exudate or fluid within the alveoli, which is making the density of the parenchyma go up, or else sometimes even in septal thickening, which is too subtle to be detected, still it is causing the increase, and the inflammatory or exudates can cause the overall density to increase a little bit. So more than UIP, it is pointing towards an SIP, but in those probable UIP patterns and other in the spectrum, if you are coming towards away from definitive UIP, you might still see some ground glass. But there are other conditions which are not related to rheumatological diseases much, which commonly give ground glass. So then bronchiectasis, I'm sure everybody knows, but just sometimes it might be very subtle. So if you look carefully at these, like I pointed out earlier, you do not see these bronchi in the extreme bases or towards the periphery of the lung normally. So when you are seeing them in an area of ground glass, you have to look ground glass or honeycombing, then that indicates it's traction bronchiectasis. Sometimes with like NSIP, even if it is a fibrotic type, you might see traction bronchiectasis occurring in it. And this is the sort of the very old description, radiological description, the signet ring appearance, where because all the time the bronchus is accompanied by, like to the secondary pulmonary lobule level, the bronchus is accompanied by an artery, and they are mostly of the same caliber. So if the bronchus is dilating, you can say that confidently by looking at this appearance. If the bronchus is dilated, you'll get this signet ring appearance. So organizing pneumonia is another thing that will commonly be seen in the rheumatological diseases, maybe in rheumatoid arthritis and all. So where there is no ground glass, and you now, like I said earlier, if you look at these areas where there is ground glass, you can still see the vessels. But if you look at this part where there is frank consolidation, you can see the air bronchogram, but you do not see the vessels through it. So then this mixture of this is mainly peribronchoascular, and you see this ground glass and consolidation areas in organizing pneumonia. There might be some dilatation of bronchi later on, and you have this atoll sign, which is mostly seen in cryptogenic ones. So I will demonstrate it here. Then another specific thing that you see in Sjogren's and SLE is lymphocytic interstitial pneumonia or lymphoid interstitial pneumonitis, which is mainly ground glass, but you get some cysts forming in the lungs with lip. This, of course, when we see in children, we do not attribute it to Sjogren's when we think of HIV, but in adults, in your setup, commonly this is seen in Sjogren's disease, where there is a lot of ground glass, and these are the hallmarks: ground glass density as well as the cyst formation. So for completion's sake, I included a few patterns, other patterns. Nodular pattern is not very difficult to identify. It's just maybe there are several ways where nodules may deposit, but it may not be very relevant to rheumatological conditions. But you can have it along the fibrous walls, and you can have central lobular nodules. Then you have random nodules, like in miliary TB, you get it everywhere. And as I told you, mosaic attenuation is kind of like a mixture of both, where some parts of the lung may be hyperattenuating and some parts may be hypoattenuating. So we look at vascular paucity and identify which part is pathological. This is usually seen in air trapping, like in bronchiolitis obliterans, you can see this pattern. Then this is strain bad opacity. I'm not sure like how often you all encounter this in your practice of purely rheumatological conditions, where this is likened to a tree without leaves, which is budding, and there are little blade-like structures at the end of these branches, just like that. At the end of the bronchial tree, you get little flower bud-like structures forming. This indicates there's something endobronchially spreading, like tuberculosis, bronchopneumonia. All these can have this strain bud opacities. So that kind of like concludes my short lecture. This I thought I'd just show, like, if you can share your thoughts with me as to how we work this up. This is honeycombing. You would all agree, coarse honeycombing, and it is subpleural in distribution because this is also at the base and predominantly basal. So this, and along with that, you see minimum or no ground glass density, and you see traction bronchiectasis. So this is how we sort of say this is definitive UIP type when we diagnose this. And here I have another one where if you compare with this slide, the honeycombs are fine, they're smaller, and you have intervening ground glass. So because of this, and also it has, it doesn't show any immediate subpleural sparing, but it does not give you that nice gradient like in the earlier one. So this one goes more towards NSIP because there's ground glass predominance, and also it has no basal gradient, basal predominance. But it is of a fibrotic type because you can see a little bit of traction bronchiectasis. So that concludes my lecture. If there are any questions.
Thank you, everyone. Good morning. I'm Hasara Jayasekara, Senior Registrar in Rheumatology and Rehabilitation, National Hospital, Sri Lanka. So I would like to introduce our first patient for the day, Mr. S. He's a 38-year-old male, a driver from Kiribati. We first encountered Mr. S in 2023 when he was referred to rheumatology by dermatology for further evaluation of diffuse cutaneous systemic sclerosis with features of evolving pulmonary involvement. So Mr. S had a long-standing Raynaud's phenomenon for around 3 years, and he presented to dermatology with progressive skin tightening for 1 year duration, which was mostly pronounced over his face, anterior chest, as well as in his hands, where he found there was sclerodactyly as well as digital pitting. He also complained of arthralgia, predominantly small joints of the hands, and he also had a dyspnea on exertion, gradually progressive MMRC class 2. He complained of a dry cough, GORD symptoms, as well as dysphagia. However, Mr. S did not have any constitutional symptoms, no chest pain, palpitations, or syncope. He did not have a history of fever, oral ulcers, malarash, photosensitivity, Zika symptoms, hematuria or froth urine, and any ophthalmological involvement. So his background was unremarkable. On examination, Mr. S had a shiny, tight skin over his face, upper limbs and lower limbs, as well as anterior chest. And the skin thickening extended proximal to the elbow joint and knee joints, which is suggestive of diffuse cutaneous systemic sclerosis phenotype. He had a prominent pinch nose, microstomia, digital pitting scars. He had some healed digital ulcers in the absence of active ulcers. He also had Raynaud's phenomenon. So these pictures were taken with the consent of my patient. As you can see, in 2019, patient had a full face. This was before any Raynaud's or skin thickening. By 2023, as you can see, he has a very prominent pinch nose. I'm not sure whether you are able to appreciate the shiny, tight skin over the forehead as well. And he also had microstomia. On his hand examination, in the first picture, you can see the pale periphery suggestive of Raynaud's phenomenon. In the second picture, he has some digital ulcers. The tips you can see. And on musculoskeletal system examination, he complained of small joint tenderness. However, there was no erosive arthritis clinically, and there was no proximal muscle weakness. In respiratory system examination, we found there were bibasal fine end inspiratory crepitations suggestive of interstitial lung disease. Cardiovascular system did not reveal a pulmonary hypertension, and abdominal system as well as neurological examination was unremarkable. So investigations. So his basic investigations were non-revealing with a normal full blood count, normal hemoglobin as well as a normal blood picture. He had slightly elevated ESR at 34 with normal CRP. His renal and liver functions were normal. Urine analysis did not reveal any proteinuria or hematuria. His immunology, however, came as a surprise to us. Even though we were ready to see this anti-SCL70 antibody positivity, what we were not very prepared to see is this anti-dsDNA positivity. He had an ANA positivity more than 1 in 160 nuclear homogeneous pattern as well, and his anti-UNRNP and anti-centrobia antibodies came back negative. Since he had a positive dsDNA, we went ahead with complement levels, and they both came back low. His 2D echocardiogram did not reveal a pulmonary hypertension. He had normal functions, and this is his HRCT.
If you can run that again, I will try to speak as we go on. Looking at the position of the lung bases, the lungs seem to have normal expansion, and there is fine, I hope you can appreciate this fine ground glass opacities in the dependent positions, but and close to the bases as well, in the lower lobes mainly, in the dependent positions of the lower lobes, and I saw a little bit of changes in the right upper lobe as well. But I saw some immediate subpleural scarring. You can appreciate it in the third run. We'll try to find that there. You can see the immediate subpleural is there, and the ground glass density is definitely there. I do think I see a little bit of bronchiectasis as well. So even in the upper lobes, you do see a little bit with some fine septal thickenings, mainly in the upper lobes. I didn't see any honeycombing. So this pattern favors MSIP pattern, and of it also more of a cellular pattern, I would say. So this looks like cellular MSIP. I would like your opinion as well, whether it's clinically compatible with the setup.
Yeah, I agree with you. Actually, it's pattern is even though I mean like this it's very subtle and it is quite extensive. I think very informative. Kind of cellular inside pattern is quite a ground glass, and there are certain areas necessary platforms that mean that the ground glass is real, and its image is kind of discrete image, and so therefore you are very technical aspect. But I have to highlight the audience about the dilated resources, and that gives us that the evidence is patient have a sustained scleral spectrum ILD because it's dilated resources, but definitely we see in patients with these systemic sclerosis spectrum. So initially it's dilated spectrum throughout the time thorax. The expect CTD and the expect the script.
Yes, thank you for that expertise. So as you have correctly mentioned, the patient's HRCT report came back as minimal fibrotic changes in bilateral lung bases with some ground glass opacities with intervening interlobar septal thickening and few sub-centimeter size cysts in posterior subpleural regions of bilateral lower lobes. So this is Mr. S's pulmonary function test in 2023. As you can see, it's slight FE1, FEC slightly reduced with total lung capacity slightly reduced. However, this is reasonable for a patient with systemic sclerosis, and unfortunately, the diffusion was not, studies were not done.
Yeah, I'd like to add a few things about, I mean, so this FEC is, even though it's mildly restricted, as Dr. Johnson mentioned in the morning, this FEC does not reflect the true ILD. There it's very important to discuss about the DFC. I mean, DFC could have been kind of given us a true picture of the extent of the ILD because it's diffuse involvement of the ground glass and with this possible vascular involvement. I mean, can be really kind of interpreted or kind of they give a flag when you do the DL. So it's not available in most of the centers. I mean, only few centers available. But it's the value of the DLs you're having here, because don't get falsely reassured with this FEC being mildly. So we are dealing with the radiologically quite extensive ILD, which is involving almost all prisons.
Thank you, sir. So we came to the diagnosis of systemic sclerosis and SLE overlap syndrome, with him having diffuse cutaneous systemic sclerosis phenotype, which is complicated with systemic autoimmune rheumatic disease associated interstitial lung disease with MSIP pattern. He had some immunological features of SLE, however, no overt clinical features of SLE were noted. So this is a very basic timeline of our patient. In 2020, he had Raynaud's phenomenon. In 2022, that is 2 years after the onset of Raynaud's, he has developed this progressive skin thickening. And in 3 years' time, or after 1 year of skin thickening, patient has developed symptomatic interstitial lung disease. So let's turn to our experts. So how would you like to proceed here?
At this point, we had 2020 and Raynaud's phenomenon and also skin thickening. At this point, it is not detected of any high risk factors for ILD.
No.
Our timeline about the screening of ILD.
So at that point, he was just a male with Raynaud's. That can be very common, but the fact that it was male sex and his age of onset would be concerned. Usually Raynaud's phenomenon occurs less than the age of 40. And so this would be the kind of person I would want to follow clinically at least once a year to evaluate for disease progression. And certainly by 2022, we see the evidence of this progression. You know, if I was going to just summarize some of the worrying features in the history that you presented, is that we have male, rapidly progressive, early diffuse disease, and elevated inflammatory markers. So these are all poor prognostic signs right from 2022. The point about the lupus serology is I agree with you, but it's a lupus overlap syndrome. You know, there's the colloquial term of lupoderma, you know, overlap of lupus and scleroderma, but his lupus manifestations are non-existent. This is a predominantly systemic sclerosis.
ILD screening before 2020.
I mean, yeah, exactly. I mean, if you're going by the ERS, I mean, it comes under the universal screening. So basically, but I mean, in our country, we can't afford this universal screening because we did a gap analysis in Sri Lanka where our average patient with suspected ILD wait for 3 months to get a HRCT to diagnose ILD. So I mean, how in a country that we can recommend HRCT for the screening? So yeah, I mean, I would agree with we need a risk-based assessment. But I mean, in future, we are considering this ultrasound scan and things like that. But I mean, so this patient could have been kind of observed and then look for this kind of with the early progression. We can do HRCT or we can do ultrasound scan and just and come to idea that's an ILD. But this patient at the time that if you found there are basal crepitations at the time of the diagnosis, the HRCT went done then and there. So if the lung is clinically normal, then the issue comes. It is ULIS, HRCT, but if it is other, I mean, our part of the world can't do. But there's no doubt if there are basal crackers at the time of the initial assessment, HRCT should have been done then and there because it gives us idea that's interstitial lung disease by itself. You don't need any other modality if you can hear the well crackers in the lung basis.
So if you diagnose systemic, usually we do at that time itself HRCT. This patient was followed at Rheumatology and 1 year later, so at the referral at that time only, so we did the HRCT. At that usually we do it then and there. Whenever we diagnose systemic, so that's a must, I think.
I used to like to add that our radiology department also because arrange HRCT actually at the beginning to screen. We are fortunate to have that facility in Kandy, which is the radiology department. So we are able to do HRCT in almost all patients.
I'd like to think about this DSD positivity, and then we are considering based on the immunology considering as a necessarily Ebola. But I'd like to know the kind of what's the method that you have used to test this immunoblock method, and what is the positivity? Is it borderline positivity or significant positivity? And what is the method they have used? Because we have a lot of substandard investigations, especially in handling this investigation. So I'd like to know what is the test that you have done, and what is the kind of positivity? Is it borderline positivity or significant positivity in the DSD?
So AMA testing was done with immunofluorescence method, and the theta was more than 1 in 160 nuclear homogeneous pattern. Unfortunately for DSDNA, we do not have a theta.
I think it's because it's homogeneous in every pattern, and SL70 positivity also there, so DSDNA should be in significant thetas because it has already been the speckled pattern. So it should be like
So, is it possible to have low serum complements in cystic sclerosis?
So yes. So we know that less than 10% of systemic sclerosis patients can have a positive double-stranded DNA, and we can also see hypoalbuminemia. It's usually just C3, not C3 and C4. And I believe in this case we have both. So the combination of all three, the double-stranded DNA, low C3, low C4, then you have to start to question about.
DNA panel.
Yes, madam.
DNA panel from
Yes. So at this point, we went ahead with a multidisciplinary approach, and patient was started on MMF 1 gram BD. And steroids were not given due to the risk of scleroderma renal crisis, even though there was hypocomplementemia and suggestive of SLE features. Patient had a very good clinical response. So we move on to 2024. So by this time, patient's skin thickening is under control, and so was Raynaud's phenomenon. Shortness of breath on exertion has come down to MMRC 0 to 1 level, and patient is clinically well. And this is his HRCT.
Please. So the earlier changes are still persistent, and I'm seeing a few cyst formations in the subdural regions of the lobes, and I'm seeing a little bit more extensive involvement of the upper lobes as well, maybe the anterior parts also earlier. I don't know if it was just the way I perceived, but there was less involvement, in my opinion, in the anterior parts of the right middle lobe and the medulla. I did see that being involved much, but there's some more septal thickening, and there seems to be subtle progression from the previous HRCT. The ground glass is more striking in this CT. This formation, septal thickenings, they are more pronounced. So, I would assume that this is a little bit more progressive compared to the previous CT.
Yes, madam. So thank you for that input. As you have correctly identified, so there is mild progression of the disease compared to the last CT that was done in 2023. So this time, they say there are intervening interlobar septal thickening and few sub-centimeter size cysts seen in the posterior subpleural and parenchymal regions in bilateral lower lobes, with lateral segment of the right middle lobe and inferior lingular segment involvement as well. And there is mild bronchiectasis as well. So this is his pulmonary function test in 2024. for your convenience, I have added the 2023 details at the end as well. So FEV1 reduced a little bit, FVC again 69%, and from the predicted value, with total lung capacity at 69%, and this time we were able to perform diffusion studies, and it is at 55% of the predicted value.
Yeah, so basically the HRCT scan done in 2024 has evidence of progression in the extent of the cloudless, and also that we are now talking about this air-space dilation, and there are two ways of kind of progression. One is through the reticulation of the fibers, and now again we are talking about newly about this emphysematous destruction or the air-space dilatation as an interstitial activity, something very new that we have. So this patient has this subpleural air-space dilatation with feature of progression. So this patient has evidence of radiological progression. And physiologically, actually, that if we see about 5% and we don't have the DLs to begin with, so therefore it's a difficult comment on that. But I would consider this patient as 2 out of 3 criteria of progression. But only problem now that if there is progression into fibrosis, I mean, there's no evidence of fibrosis radiological. So then whether we should start antifibrotics if it is progressive fibrosis? No, it is not the case. And I'd like to highlight, I like to kind of ask about Sindhu because this patient comes in 2023. I mean, I feel that it's a classic focus clinical trial inclusion patient. What do you think?
Yes.
So this is a focus, basically, focus trial. Inclusion criteria, all the inclusion criteria focus trial is fulfilled. So, I mean, so still, even though it's progressive, there's a place for immunomodulation, immunosuppression. So it's not for antifibrotics, but to further escalation of immunosuppression. I don't have any doubts. You consider TOSI here, tocilizumab, and even at the beginning, but not now actually. I mean, I'd ask from my rheumatology colleagues and about further escalation of immunomodulation. So I'm not thinking at all about immunosuppression, even though it is progressive.
So what do you think for the initial management? What is start at the very beginning? This progression that we do.
Thank you. So, we all agree that the diagnosis was systemic sclerosis associated ILD. And according to the ACR chest guidelines, first ILD treatment is phenylate. So I agree wholeheartedly with the treatment. But what was interesting in the initial presentation of the case was the patient had arthralgia in their history and had elevated ESR. So, when my colleague here talked about classic focused inclusion criteria, the fact that this patient had elevated inflammatory markers and possibly concomitant inflammatory arthritis, when you think about what is the next therapy, I agree with my colleague that perhaps tocilizumab is the next good choice because it'll treat both the progressive ILD as well as the. Now, doing a swollen joint count in someone with diffuse cutaneous disease ought to be very challenging. These patients have puffy fingers, they have tight skin. It sounds like he had proximal involvement. And so, ideally, you have a swollen joint count that you can monitor response to therapy, but I will admit that it is very challenging to detect him swollen joints.
You can use the modified Rodnan score, isn't it? Initially.
So modified Rodnan skin score is an excellent tool for the monitoring of skin, but in his case, his skin stabilized by the time his ILD progressed. So at this point, it's going to be hard to use.
So possibility is not freely available. So because of that, we would like to think about rituximab, cobalt rituximab.
No, it's not. We cannot not as numerous and we have given it's no,
Thank you. So understanding the Sri Lankan context, if tocilizumab is not readily available, then rituximab is an excellent option. It is consistent with the ACR guidelines. So it's available. It's interesting what's available in each country. So in the Canadian context, tocilizumab is more readily available because rituximab is far more expensive. So that's why for us, toci is the easier option. But yes, rituximab is an excellent option.
normalization of these inflammatory markers prior to the initiation of infliximab, I would not let that be a barrier to the lungs are progressing. It's something. I just prefer the immunosuppressive that'll treat more than just the ILD. No, inflammatory.
Specific patient, the background of lupus as well. You have to use an process.
Yes. Actually, we evaluated this patient and with the FDT, the decision was actually, since there's no really 10% decline of these values, we were to continue the same management. So the patient was on MMF 1 gram BD, it's CQ 200, sildenafil 25, and nifedipine fluoxetine for his Raynaud's phenomenon, famotidine domperidone for GI symptoms, and other supportive therapies. Since we came to the decision that this was rather a stable ILD because the patient was asymptomatic and the inflammatory markers have completely stabilized. So then this same treatment was continued for 1 more year, and then came the pivotal moment where in December 2025, patient came back with worsening of shortness of breath on exertion with MMRC scale 2 to 3. However, there were no other features of disease flare. His 2-day echo did not reveal a pulmonary hypertension with normal TRPG, and this was his HRCT.
Comparing with second CT, my opinion would be that the changes noted in the second CT are still there in the third CT. The ground gas density is slightly more accentuated, but the cyst formation, septal thickening, and the ground peak cases, they have not progressed. So the extent of involvement is similar to the second CT. There's mild pleural thickening, which I did not like more than what I saw earlier. But the fibrotic appearance has not progressed. It's the ground gas is more accentuated, and the extent is the same. So I would consider this more or less similar extent of involvement with more pronounced ground gas, which may be of uncertain significance clinically. So overall, it's fairly stable, but this is how far apart are these?
This is 1 year apart, right?
From the second CT.
Yes.
Yeah. So over 1 year, this is fairly stable in my opinion.
I'd like to highlight that there are new areas of involvement. I mean, if you consider the gliometal injury, there are new areas of this gas restoration. Consider the lung phase, and consider this is slightly more rectification as well. So, I mean, it's better.
So thank you for that input, sir.
Now, what about the ones as well as the DL0 after 1 year? At the time of third CT,
So this is his pulmonary function test in 2025. Let me put this table for your convenience. So you have 2023, 2024 as well as 2025 values. Now this has significantly worsened. So back to the experts. How would you like to proceed at this point?
So, I still concur that this patient needs an added therapy. So I would add a biologic to the mycophenolate if it's not been done already. So rituximab or tocilizumab. If this is, had he been on a biologic and progressed on rituximab, then I would start thinking about cyclophosphamide.
Actually, what I understand is we have to, from the beginning, we have to identify the high-risk patients, and because this patient is male gender and diffuse disease, and SCA70 is positive, and ESR also elevated, so this is a high-risk patient, but then MMA would be the first choice, that's correct. But if it is like progressing, obviously this patient is progressing, and in that case, the wisely we have to select, I think, tocilizumab. That because rituximab rather than the tocilizumab, what is available generally. So rituximab is cheaper because it's a biosimilar and maybe like efficacy also we have doubts. So in that case, we have to wisely select patients, high-risk patients, and start tocilizumab from the beginning. That's what my.
Still, madam, I mean, this, yeah, so still, I mean, if you consider this, what do you call this, I mean, not yet, yeah. So basically, if you consider the definition of PPF, I feel still the optimum management of immunomodulation, and we have to consider that. So I'd like to ask Dr. Johnson, if you don't have none of the violations, maybe tocilizumab or rituximab, so why don't you increase the amendment to 1.5 gram BD and that would have an option, isn't it?
Yes, absolutely. Maximize.
Yeah.
So that was my response. Yes, if this was progression on at the second year, we already saw some evidence. So at that point, I would have started a biologic, either tocilizumab or rituximab. So let's assume that happened, and now we see this third CT center progressing.
Because now I think it's a time that we have to use all our weapons here, because the patient has crossed the DLC of 40. That patient is now in the transplant region, and it's quite worried. We don't have a lung transplant program in Sri Lanka, and so I think it's a time that we have to use all our weapons to save the lung.
Other thing is in Asians, even in lupus cohort in Asians, in 1 gram BD, that's it seems to be effective according to studies. That's why we are using 1 gram BD dose in our patients. So I think MMA rather than increasing MMA, we have to go for another option.
Yes, so thank you for that input. So this patient was given IV rituximab 2 doses, and currently he is awaiting repeat HRCT and pulmonary function test. However, patient reports symptomatic improvement. So this is our discussion. So if the patient...
I'd like to add one more thing actually, that the symptomatic improvement from the beginning could have been due to the skin itself, because it is diffuse cutaneous disease, so that the skin is involved around the thorax as well. So when you give the treatment, you can see that clearly there's a discrepancy between the initial CT and the second CT. The CT was slightly progressing, patient is clinically improving. Could have been the skin around the chest. That's why the DLC and the KC is utterly important in this case, because if you have the DLC and the KC from the beginning, that you have given an idea that, I mean, this patient is, even though it's clinically better because of the skin, or, I mean, there's still ILD problems. I'm just highlighting some of the fact that I think we have to think broadly. Still in this patient, when you are discussing the DLC, also it's very important to discuss the KCO as well, because diffuse cutaneous and the KCO is very important as the DLCO. Just a small comment.
Actually, at National Hospital now, specific division, they have got a new machine, so we can do the DLCO and KCO now. Now it's readily available rather than those days earlier.
Thank you, man. That information will be really helpful. Because now I was thinking about why this patient clinically improved with this regular protection. I just thought of that could be the skin around the chest.
But there was not much skin thickening.
Initially in 2022, there has been skin thickening. Yeah, by the yes, anterior chest involvement has been there, madam. So for our discussion, if this patient is stable in the current condition, how would you proceed? If this patient gets better, would you de-escalate? And if this patient worsens, what are the agents to escalate?
so the thing about systemic sclerosis is a systemic disease. We've been focusing our discussion on lungs and to a lesser extent skin and joints. But there are other things. So it would be important to know what's happening with the muscles and following the CK. And then what's been happening with the inflammatory markers. So certainly a rheumatologist should be monitoring ESR, CRP, CK throughout the management. Because that'll be an indicator, are they responding to therapy or are we losing efficacy? Often when we initiate mycophenolate, phosphoride, or tocilizumab, we'll see an improvement in these inflammatory markers. But then they start to rise again. And that can occur before the follow-up CT scan. So often if I see a CK starting to rise or an ESR or CRP starting to rise, that's a hint to me that something is happening and that we're probably losing efficacy. In terms of what would we do, I think we spoke about this. Now that people on rituximab, if they're progressing, but even then, I would only use 6 months, maximum year. Then, how do we de-escalate? De-escalation to mycophenolate, or if that's not tolerable, then the old-fashioned way is
What about perhaps maintenance?
if the patient progressed on TOS, then sure, TUX maintenance. But if the patient progressed on TUX, then I'm a little bit reticent to use TUX.
Patient has been monitoring the exercise going to do it 6 monthly when the patient is stable.
So the question was, should we be continuing Q6 monthly PFTs for monitoring? And yes, guidelines will suggest we need to continue. Because that'll be one of the few ways to know, are we losing ground, achieving stabilization?
Yeah, I think, okay. As I personally, which is deteriorating and top of my phenolate, but about taking supplement. Vaccination, I think we need to think about that as well.
Yes, ma'am. I think that brings us to the end of our first case presentation. I would like to give thanks to my consultant, Dr. Monika de Silva, consultant rheumatologist, National Hospital Sri Lanka, the College of Specialists in Rheumatology and Rehabilitation Sri Lanka, as well as the Kandy Society of Medicine, our experts in the MD team, as well as the patient. Thank you.
Thank you, Dr. Jayasekar, for that engaging session. We will now move on to the second case presentation of the day. I would like to invite Dr. Kasuni Suwandika, Senior Registrar in Rheumatology and Rehabilitation at National Hospital Sri Lanka. The floor is yours.
Good morning. I'm Kasuni, Senior Registrar in Rheumatology and Rehabilitation, National Hospital Sri Lanka. So, patient is a 46-year-old housewife, mother of 2 children. The initial presentation was 10 years ago, when she was at the age of 36 years. She initially had an inflammatory type of shoulder joint pain with later involvement of both bilateral, small and large joints. And then the time of evaluation, she was found to have high ESR and rheumatoid factor was positive, and anti-CCP antibody was also positive. And there was a negative ANA, but that was done in an agglutination method. However, clinical picture, there was not tallying with other rheumatological illnesses. And then that time she was diagnosed to have seropositive rheumatoid arthritis, and she was followed up and started on methotrexate by a rheumatologist at a private sector for 5 years. And she had a good response. So during first 4 years of illness, she had a good adherence to treatment during initial 2 years. And then after 2 years for 6 months duration, she has taken alternative medications and then came back to rheumatology care. Since then, she has had good pharmacoadherence, and also due to joint symptoms, leflunomide was also added. However, those reports are not available with the patient now. In 2020, 4 years after the onset of illness, patient developed shortness of breath on exertion. MMRC scale was 2 to 3. She couldn't complete a 3-word sentence while walking or hurrying. There was no dry cough, wheezing, or heart failure symptoms, and activities of daily living was affected. However, she couldn't seek medical attention properly due to COVID-19 lockdown during this period. In August, next year, August, 5 years after the onset of illness, she had fever, dry cough, and shortness of breath, and admitted on 21st day of illness to infectious disease hospital after being diagnosed to have COVID-19 infection with PCR. And while treating there, she was desaturated at 6-minute walking test with 93%. And but however, she was not required oxygen therapy or ICU admissions, and found to have diabetes mellitus at the same time. And she was X-ray was taken due to changes. HRCT was done. Those HRCT findings are not available. The video console is not available. So the report says there is patchy subpleural consolidation in both upper lobes with peribronchial consolidation in right middle lobe, and both lower lobes also demonstrate peripheral and peribronchial consolidations. Some demonstrate resolving changes, no residual organizing pneumonia, and there is inter and intralobular interstitial thickening predominantly involving both lower lobes with basal honeycombing, and there is mild degree of interlobar interstitial thickening is also seen in the rest of the lung fields, and also there were ground glass changes in both lower lobes. So comment was given as moderate degree of probably peak to early absorption stage COVID pneumonia, and basal fibrosis with honeycombing is suspicious for pre-existing interstitial lung disease.
Actually, do you have anything like the concerns?
Yeah, given the description, I have to agree with the comment because now the acute presentation is with COVID, so most likely those consolidation patches, the peribronchial inflammation, all could be attributed to that. But the honeycombing has to be due to some pre-existing thing.
Due to persistent tachycardia and low saturation because of the background of COVID infection, she has undergone CTPA as well. And there was also subpleural consolidation with interstitial thickening and ground glass opacities, and suggestive of resolving COVID lung changes. And degree of involvement is less compared to previous, and basal honeycombing is again noted. And there was no bronchiectasis or organizing pneumonia. The comment was given with late stage COVID lung changes with probable underlying interstitial lung disease. So other investigations which were done at this point was 2D echocardiogram was done, which was normal, and WBC was 7,000, HB was 11.7, platelet was 419, ESR was 25, CRP was 2.5. So,
Patients was because of COVID, but unfortunately because of the lockdown all over the country. So, should patients come to the clinic for care because of this thing? So, it's probably the time we could have done screening.
Thank you. So, yeah, I mean, a few comments about the CT scan. I mean, I'm sure that my colleague will agree around the case kind of giving in the CT report about radiological diagnosis, saying constellation is COVID, but it gives us a lot of kind of controversies because, I mean, in a remote autoimmune patient with autoimmune disease, constellation, there are so many cases even it's COVID by radiology. So therefore I kind of I'd rather kind of be very cautious by when the radiologist reporting consultation with the etiological diagnosis in the report, because the clinical team could be biased on that. And then
It had
And then-
genetics-induced lung fibrosis.
So that's really what I really like if they can keep the diagnosis open. I mean, they can clearly say it's a consolidation. They can say it's infective if they really think. Labeling a steroid and really totally kind of isn't accurate. So it's about mitometabolic report, and then come to the so I mean it's a year that I mean there's shutdown in the kind of community, and there's some struggling because patients are pouring with the COVID-19 problems, and all the units are kind of struggling to cope up with. So we are in a kind of and not only in Sri Lanka but also all the kind of entire world. For example, NHS, UK, and the UK and Canada as well. I'm sure that all they expose all the kind of vaccine system. It's in one way that that's things positive. But I think that the screening that being totally possible in this patient, even though this patient is a high risk patient in Sri Lanka, so totally kind of that we missed that opportunity. But I still I think that's quite a lot we could do to this patient, and we'll see how it goes. But yeah, that window could have been missed. But this patient is kind of the ideal candidate that we start to screen for patient.
I think in the presentation, I mentioned fever. So that is that's atypical for ILD and atypical for progression of ILD. So that's when you start to need to invoke other things. So infection, COVID, or other kind of bacterial infection or other viruses, or methotrexate pneumonitis, although extremely rare. The fact that the fever was included did not make you rush to say that this is ILD. And then, as all the reasons you said, screening during that period was very difficult to hold. And so I don't think anybody faulted for inability to screen. But if someone has an infection, I don't think pulmonary function tests are going to be that helpful for any of the diagnostic entities. I think if we're invoking either methotrexate toxicity, COVID-19, any other viral or bacterial infection, I would say, let's wait this out and then repeat the CT scan and then do pulmonary function test before an immunosuppressive therapy decision.
Okay.
This patient had COVID, your PCR was positive. This patient had COVID infection.
Yeah, but still, madam, but just labeling a consolidation in a CT scan as COVID, it has unique consequences. Most of the COVID, I mean, I was involved in a lot of COVID management because most of the patients, even though they have COVID positivity in their rapid antigen test and all, but they died of some other problems. And there are a lot of bacterial pneumonias. There are a lot of fungal infections. So that's why I'm just kind of disagreeing with this labeling detail.
Yeah. But they mentioned like underlying interstitial disease also.
Yeah, exactly. Yeah.
But it makes us to prevent very scientific and then sometimes NTX-induced lung fibrosis. Then when that statement is there, sometimes before patient has lost, it's actually rheumatoid-induced rheumatoid lung disease. It's not infection. That's why I think when they tell these problems in the starting, because patient is not sleep controlling their teeth, it becomes a bit of a problem. Please starting it when that.
Still, I was telling you about oxygen pneumonia because we are not just to kind of use NDP culture, and we try to kind of fully diagnosed by a single specialty, and that's what happened. So I think the culture is changing now. We are evolving to the more shared care protocols now. So things will be kind of right for the situation.
I would like to add something to that because this is, I think, a communication gap very clearly. If the clinician can actually explain the required area where they are, what their real interest is, I think also, like he said very correctly, NPT discussions are important in these respects because we try to identify patterns and then the clinician knows the whole picture. Most of the time we don't get the whole picture, we just get 2 sentences. So that's I think we have to think from the side of the radiologist here.
Totally agree. Yeah.
And we want to see what happens to the patient.
So after the child CT diagnosis and also the background history of COVID-19 infection, her methotrexate was withheld by the treating team at IDH, and then oral prednisolone 30 milligram started and planned to continue for 3 months on discharge by respiratory team. and then referred to our rheumatology team on discharge. So she presented to us 1 month later in October 2021. Upon presenting, she had a mild dry cough and SOB on exertion with MMRC scale 1 to 2. There were no joint symptoms, and on examination, she was not dyspneic at rest, and there was no active synovitis, and her hand functions were good, and there were no rheumatoid nodules. On examination of the lung, there was vesicular breathing with bibasal fine crepitations. And her investigations as WBC was 14,000 with mild neutrophil predominance, and hemoglobin was normal, and platelet was 472,000. And she was on prednisolone 30 milligram morning and inhalers. So, what could have done at this stage for this patient?
The patients out of COVID infection and at this point, patient is off methotrexate. Is it because he had COVID infection or because of COVID? What thoughts about restarting methotrexate? Doesn't have any joint involvement at this point. Probably. So, what is our stance about restarting methotrexate at this point?
So she has high patients. It is still the residual level of the non-people straight away say that it is going to ILD.
I mean, I'd like to kind of give the benefit of the doubt to the clinicians who are treating these patients at the time at the COVID, because we didn't know what to do. I mean, these patients, unless this recovery trial came in 2021, and we were really getting everything under the sun, and we don't know it's COVID, there is something else. So I think that I can still remember we were kind of doing all the things still at the time. But anyway, the recovery trial, we had some evidence of being serious and all. But they have stopped the methotrexate because of things like COVID infection might have kind of some negative effect. I totally kind of be supportive to the clinicians there, because we don't know what to do at the time of the situation. There's no evidence of any data at all, and later one of prospective studies and retrospective studies came in. But yeah, so basically, I mean, that's fine. I mean, but still, I mean, now we know, when we now retrospectively we know, COVID does not cause persistent lung fibrosis. So, there's a retrospective information. By the experience, at least about 5 years now, we know actually it does not cause. So, if the patients are fibrosing due to COVID, we know there should be something underneath. And the most important fact is actually COVID, as well as most of the viral infections, can lead to autoimmune dysregulation. So this immune dysregulation triggers an autoimmune process itself, not only in a patient with rheumatoid arthritis, but itself in a patient who is completely normal previously and could have been kind of initiated by a COVID-19 infection to start a new autoimmune dysregulation process by this viral infection. That could lead to this. So now we know, and if there is evidence of fibrosis in a COVID-19 patient, we should look for the factors, and it can't be COVID itself. And it's very, very rare to have persistent lung fibrosis due to COVID. And most of the changes we saw as fibrosis in the previous CT scan, now with the follow-up assessment, we know it's completely resolved now.
Well, I mean, if you look at the ECR guidelines would say that you should not initiate methotrexate for the treatment of ILD. And so if we say that the crepitations are not COVID related, this is independent disease, then I think the disease that we need to treat today is ILD. So I would be inclined to say methylphenolate for the ILD, knowing that as the prednisone is reduced, there's going to be a risk of joint flare, and the methylphenolate's going to do nothing to the joint. That the next level. For today, I would say treat the ILD because that's the problem she has.
I'd like to kind of highlight one fact about this rituximab. I mean, because it's particularly in COVID, we know actually it has a So we had few patients and one biologist who particularly died with COVID-19. So I think rituximab could have been a real contraindication here. We were not thinking of any, but I have to highlight that fact. When there's COVID-19, you always think about rituximab. You should never think about that.
Then, following our visit to our unit, then we started her on MMF 500 milligram BD, and later increased up to 1 gram BD, and prednisolone tapering off started. And later, as patient developed some joint symptoms, we started her on HCQ 200 milligram daily. So by January 2022, she was on prednisolone 5 milligram MANE, HCQ 200 milligram daily, MMF 1 gram BD, and inhalers. Aspirin was aspirin and MDI Beckley. And then she complained of persisting shortness of breath on exertion. And for an screening, as pulmonary function test got delayed, the respiratory team has done 6-minute walking test. You can see there are some desaturation, and also distances also has been reduced to 390 after 6 minutes. And then HRCT was available. So that also the console is not available, only the report is available, which said there's a ILD with craniocaudal gradient, significant ground glass with patchy traction bronchiectasis predominantly along the bases. There are no areas of consolidation or honeycombing. There are areas of inter and perilobular septal thickening with cluster of traction bronchiectasis seen in bilateral basal regions. The impression was fibrotic NSIP with underlying minor volume post-COVID lung abnormalities.
It's clear that COVID changes as goes away, and it's clear that we have the argument because
Yeah, I would agree with you. Looks like all the descriptors are matching with the fibrotic NSIP. It's the same basal predominant, the ground glass predominant, and clusters of traction bronchiectasis in the bases.
No.
This is after MMF
1 gram BD for around 1 month, 1 to 2 months.
Probably that NSIP part would have been obscured by the consultations in the previous.
So the pulmonary function test was available 6 months later. Actually, there's no total lung volumes, and DSCO is not available at that time. So you can see the forced vital capacity was 1.08, which is 33%, and FEV1 was 1.02, and FEV1 to FVC ratio is like 115%. So the restriction was suspected. Then by that time, patients even though there's established fibrotic NSIP type of ILD, with treatment, patient was clinically stable with same Marcy scale. So as a summary, this is the timeline of the disease up to now. 2016, she was diagnosed to have rheumatoid arthritis. 4 years later, she developed shortness of breath on exertion. Then 5 years, like one year after SOB on exertion, she found to have ILD, and MMF started, and then she became clinically stable with MMF. So this is the follow-up pulmonary function test, which was done in 2023. I have added a comparison with the test done in 2022 as well.
So a few comments about the kind of initial before comes to lung function. I mean, in ideal world, the HRCTs are fully available frequently. We could have done the HRCT before we start the MMF, and we see this consolidation of complete resolve. We know that we have baseline idea what happened to the infection before starting suppression, but in our country, it might not be the case. When it comes to the kind of assessment, the clinically kind of stable in the sense of systemically as well as from the lung point of view. However, these patients' kind of lung volumes are very, very low. Actually, it's a very, very poor kind of poor lung kind of capacity of this patient. It could be due to the kind of the performance of this patient. I'd like to see the flow volume loop of this case and see whether this patient any other kind of technical method. In that case, because being a patient with clinical stability and efficacy of therapy, I'm really, really worried. So I see whether the kind of how is the volume loop and whether there are any kind of gaps, whether there's inspirate loop and expirate loop is kind of overlapping, and there are some two technical factors before I comment about this lung function. So I'd rather kind of have an overall picture of this patient rather than basing my decisions on this lung volume, because this could have been due to a technical again this some issue with the lung function itself. If it is real, then I'll be really worried, because this patient with this much of low lung capacity, the HRCT could have been extensive lung disease. Extensive interstitial lung disease. Then we have to assess whether there's any evidence of 5.6% of fibrosis, and this level, the DLCO could have been really helpful, because at this level, there's high chance this patient has developed pulmonary hypertension. So I'm not expecting this lung function in a clinically stable patient at all. So therefore, I'd like to keep it open.
Then in the next year, HRCT test was done as a follow-up. So the video is available.
Okay, if you can please stand again. So, at the look of the position of the lung bases, I would say mildly reduced expansion and has extensive ground glass in both lung bases with some microcystic honeycombs, which are very well seen in the right side. In between, you'll see the traction ground places. And then there is fracture involvement of the right upper lobe. Like middle lobe and the upper lobe, yeah. So, if you can write it in, I would like to look us up to the spelling. So this is mostly fitting the MSIB pattern that we discussed earlier. There's some subpleural spelling in the left side that was in the base. So this seems to be involving both sides and partially involving all the lobes, more extensive in the bases, but the changes are, the appearances are towards MSIB, fibrotic MSIB, I would say, because of the traction down with and microcystic honeycomb.
So the report came as fibrotic MSIB with no interval change comparatively HRCT done on January 2022. So the same year, the pulmonary function test also repeated. However, the lung volumes and BSEO are not available. So comparative, I have added the comparison as well from the previous pulmonary function test. So as a summary from 2022 to 2025, patient was symptomatically stable with SOB on exertion with MMRC grade 2. Throughout, she has no dry cough and no wheezing, and the pulmonary function tests seems to be stable, and she was on MMF 1 gram BD and MDI aspirin 400 microgram SOS. So in January 2025, patient complained of worsening shortness of breath on exertion and dry cough. At that time, her ESR was 58 with hemoglobin of 12 and 2D echo was normal with no pulmonary hypertension. So HRCT and pulmonary function test planned. Console is available.
So generally we take a long time to compare two CTs, but running through this we generally take a long time to compare. But as like first glance, I would say again that position of the lowermost part lung base is slightly higher, so there's reduced expansion and the septal thickenings are more striking than earlier. But the basal extent, same extent was there in the previous CT. And we can move up a little bit more. The microcystic honeycombs are there and they are more striking. Yes, keep moving. Thank you. But the areas of extent, in my opinion, are like the same as earlier. So I would still call this fairly stable, unless of course you all would disagree. But to me, first class, I think it's the same extent, but the honeycombs are more striking. And area of extent wise, I would say the same is involved.
Yeah, I think areas of involvement is the same, but however, the areas which are inflamed in the previous CT scan now it looks like they are fibros. So basically, the fibrotic extent of the eye is the same, but overall extent is the same. And I mean, we can do. There are some kind of regulatory manipulations we can do, like MINIC and things. We can just remove this ground glass completely. So that after Chandima Abeysinghe, then you can see the entire areas of fibrosis and just remove this ground glass in the lung by this minimum mutation correction. So a lot of technology that you can use actually to assess the fibrosis. But we are just using a really, but in real reporting, see a lot of, we have a lot of modifications to this. We have a lot of software. So my opinion is actually that overall extension, but the fibrosis has progressed.
Like the inadequacy of treatment, or is it?
Well, I mean, it's still, I mean, it's a very political question, actually. But this patient was stable initially, and so something might have been triggered in this patient to happen more fibrosis. It could have been a simple viral infection. It could have been some some new evaluation of the kind of autoimmune process. Or simply reflux. I can see that esophagus is more dilated now, and the reflux, the gastritis, could have been triggered this fibrosis. So, yeah, I mean, I can't blame the immunosuppression.
Yeah, while we're focusing on the lungs, what else is going on with the rheumatoid, right? It's, the rheumatoid arthritis had low disease activity or was it in remission? Again, it's hard to, can't criticize retrospectively, but we always should treat whole patients, not just the lungs. So if the patient has active inflammatory arthritis, that would be another reason to escalate immunosuppressive therapy. If the patient was always in remission, well, then what we have is progression of fibrosis. So maybe now is the time to think about pirfenidone.
So this is the HRCT.
Yes, so
report.
I'd like to know the DS28 scope discussion at the time of this. See how we can if the intermediate process going right, rather than not consider antibiotic side of the something like that. So still, my threshold for antibiotics in Sri Lanka is very low. Sorry about that. So compared to my Canadian colleagues, so we tend to kind of, I think we always go for kind of escalating. So yeah, I'll ask my robot guy to assess the joints and see how the information is going on, and then I'll add it up.
So the HRCT reporting came as the HRCT appearance of fibrotic ILD with stable distribution. So then, because of the then the HRCT was available. Pulmonary function test was available. So there you can see the chart and flow volume loops and the comparison between the December 2024 spirometry results and April 2025 results.
Yeah. Flow volume looks not too bad.
Then she underwent the pulmonary function test to assess the DLCO as well, but it couldn't perform as patient having very low vital capacity, which was less than 1 liter, and total lung volume was by that time it was 4.31, and then a multidisciplinary meeting was held at National Hospital Respiratory Disease with the participation of respiratory physicians and radiologists, and they have compared HRCTs and pulmonary function test, and the conclusion was progressive UIP type of ILD, and plan was to increase dose of MMF 1.5 gram PD, and also they have plan to get treating rheumatology team's opinion on escalation of treatment to IV rituximab, and they started patient on antifibrotics pirfenidone. So she was started on pirfenidone 200 mg TDS. After 3 days of taking pirfenidone, patient developed itchiness and there were no anaphylaxis. So then pirfenidone was withheld and planned for rituximab, and again planned for a multidisciplinary meeting at National Hospital, Sri Lanka. There, the decision was to repeat pulmonary function test and to see whether if there's a progressive ILD with FVC drop more than 10%, plan to comment on IV rituximab. So this is the repeat pulmonary function test. Lung volumes are not available this time. DSO is available. So you can see there are FVC drop by 11.8%, which is more than 10%. So what could have done at this point, according to expert?
So in a patient with FVC 30%, I'm definitely not going to wait for 10% drop. Oh my goodness, no, never. Right? So so basically, we have to be realistic, and we should, escalate even something. And again, that pirfenidone, rituximab, I do think it's a good option in this patient because mycophenolate increasing 1.5 gram PD those it takes some time to act, and but I have a kind of level of urgency here. I mean, because I mean this patient is very poor lung capacity. I think I'll straight away go for rituximab. Convincing of pirfenidone, and that's fine. I mean, we don't have much evidence that we have a lot of debate. I mean, Dr. Johnson and that going on that they should upfront combine antifibrils, or they should do a sequel, but that doesn't matter. But pirfenidone, when you start pirfenidone, one of the common side effects is the photosensitivity, and having the photosensitivity is actually not an indication to stop treatment at all. And so the thing is actually we have to correctly advise the patient how to prevent photosensitivity. I mean, I'm sure that in other countries we are asking the patient to use SF50 sunscreen, and so many advice should be given. And we have a lot of patient support for patients who are on pirfenidone. There are separate helplines. I'm sure in the case in Canada as well, that they can directly contact the nursing in charge and the specialist and get the advice. And there's so much of advice going on when you're on pirfenidone, because it has such a lot of side effects, especially the GI side effects, the photosensitivity and everything. But none of the kind of side effects are not an indication to discontinue treatment, because basically that comes under kind of proper patient education and then proper management of side effects, and giving first time that whenever you are starting pirfenidone, please advise the patient to avoid the sun as much as possible. If you absolutely want to go out, you use the kind of long sleeve and then do some clothes and sometimes use SF50 sunscreen. But our people, we have kind of clearly used, because there are so many, especially there are so many kind of so many levels of sunscreen, so it's 15, 30, and 50, but we are going to the highest sun protecting factor screen when down to pirfenidone. Yeah.
Then she was started on IV rituximab 500 milligram dose 2 weeks, 2 doses 2 weeks apart. Last dose was given in August last year, and then we repeated HRCT. The console is available.
So there's slightly reduced involvement with ground glass, but the area extent of honeycombing hasn't progressed. I do not see any new areas getting involved. So overall ground glass density seems to be slightly less compared to the previous study.
So the impression was fibrotic ILD with progressive fibrosis and interval reduction of ground glass attenuation. So this is the repeat pulmonary function test, which was done in last December after rituximab. So this is the comparison of the pulmonary function test throughout and after rituximab as well. So you can see the comparatively August, the December forced vital capacity, there's mild improvement, and the total lung capacity and DSCO, there's comparison. The total lung capacity, there's like improvement and DSCO improvement. So this is the timeline so far. This is the current status. Patient has ILD with MMRC grade 3. She complains of shortness of breath while hurrying, walking and talking while walking, and some with taking food hurriedly. And there are no pulmonary hypertension in a recent echo. She's not oxygen dependent, and she has diabetes mellitus on oral hypoglycemic agents, HbA1c of 7.7 with FBS of 174 and endocrinology follow-up, and she's currently on MMF 1.5 gram BD.
There's nothing specific.
So in this state, how can we help the patient to alleviate her symptoms and joint symptoms in remission?
Since this case quite long time, I think patient is optimized so far, and the symptoms probably related to maybe ILD, maybe contributing factors as well. So, yeah, shall we stop this case now and move on to the next case? Because time. Thank you very much. That's a nice presentation.
Thank you, Dr. Suvantika, for a very informative session. Now we move on to the final case presentation of the day. I would like to invite Dr. ProgrammeSystemic, Senior Registrar in Internal Medicine at Teaching Hospital Peradeniya, to please start the presentation.
Thank you very much for your kind introduction. And good afternoon, everybody. I'm Dr. Aruna. Give me a few minutes to... sorry for the technical issues. And I'm Dr. Aruna, Senior Registrar in Internal Medicine at Professorial Medical Unit, Teaching Hospital Peradeniya. And I know this is not a good time for another long case. So don't worry, I do have a very short case presentation. So my patient is 58 years old female from Akurana. She presented to us with loss of weight for 1 year duration. And she complained of shortness of breath for last 6 months duration, which has been worsened over last 2 weeks. So this patient has had an insidious onset of weight loss, where patient has lost about 15 kilos over last 1 year, and it has been associated with loss of appetite. And patient experienced generalized weakness, where patient attributed it to the loss of appetite. But this has been progressively worsened over time, where ultimately patient experienced difficulty in getting up from the seated position and climbing stairs, difficulty in combing hair, and patient developed bilateral knee pain while ambulating without significant knee swelling. So 8 months before the admission, patient developed pain and swelling in bilateral small joints in the hands, where most likely inflammatory type, where patient experienced aggravating symptoms in the morning and morning stiffness as well. And this has been managed by a general practitioner by giving methotrexate 10 mg weekly with several courses of steroids, where patient ultimately feels some partial resolution of symptoms, where patient not seek expert opinions since patient experience some improvement. For last 6 months, patient experienced difficulty in breathing, mainly with exertion, and it has been progressively worsened, associated with dry cough and intermittent fever. And patient has had on and off purulent sputum with high-grade fever, where patient being treated as lower respiratory tract infection as outpatient. So during the last 2 months, The patient developed excessive hair loss and no orogenital ulcers or skin thickening as of note, and no history of Raynaud's. Past medical history, surgical history, and the allergies were unremarkable. And there's a significant family history where maternal history of hypertension, but no ischemic heart diseases and no history of autoimmune rheumatological disorders. And she's married with a grown child, and she's having good financial support. In summary, so this patient has had constitutional symptoms for 1 year duration with significant weight loss, and then developed musculoskeletal symptoms, including the symptoms suggest of proximal muscle weakness and inflammatory arthritis, and then developed pulmonary symptoms in form of progressive breathlessness, and for last 2 months, patient developed some hair loss. So then on examination, patient was ill on admission, and patient was emaciated and febrile, and she's moderately pale. Other than that, patient has had patchy areas of hair loss in the background of generalized hair loss, and there were non-scarring erythematous scalp, areas of scalp, and there's no scales as well. And there's a hyperpigmented area in the anterior chest, like a V sign, but there's no shoals. There was no shoal sign, and Gottron papules were there. On musculoskeletal system examination, small joint tenderness was there, but there's no significant active synovitis. There was significant muscle tenderness, and patient has had proximal muscle weakness where the lower limbs predominant. The lower limb proximal power is around 2 out of 5. The upper limb proximal power was 3 out of 5. Cardiovascular system, hemodynamic instability was there with a marginal blood pressure with tachycardia. Other than that, there was no features of pulmonary hypertension. Respiratory examination, patient was dyspneic with a respiratory rate of 32 breaths per minute, and patient was hypoxic with a saturation of 84 on air. And during the ward stay, patient was further desaturated, where needing further escalation of treatment. And trachea was central, and auscultation, patient has had mixed fine as well as coarse crepitations from the bases up to the upper zones. And other than that, patient has had bronchial breathing patch over the left lower zone. Abdominal examination and the nervous system examination was unremarkable except the proximal muscle weakness. And the investigation-wise, patient has had neutrophilic predominance in the full blood count with moderate anemia. Platelet was initially was normal range and seems to be dropping with the subsequent assessments. Blood picture shows mixed deficiency anemia and the features of infection or inflammation with the neutrophilic leukocytosis and toxic changes. Inflammatory markers were high with CRP of 150 with ESR of 120. Renal and liver function seems to be stable except for marginally elevated creatinine and hypoalbuminemia. And this was the X-ray.
So this is a supine X-ray, and that would indicate that the patient was very ill at the time of it being taken. So the apparent enlargement of the heart and the congestion of the hilar region could be attributed to that. But even having said that, the right lung expansion seems very less than the left. And also I can see some airspace shadows actually. Airspace shadows in the periphery. I can see patchy areas of consolidation in the right lung, lower and mid zones, and also in the left lower zone, supporting the heart wall as well, and in the left mid zone also. So it's very difficult to say if there are underlying reticular shadows or not, because the areas where we look for reticulation are all obscured by consolidation.
Yes, madam, and the radiology team also agreeing with your explanation, and they have suspicion whether there are reticular nodular shadows also, since the history and the examination has some evidence of underlying fibrosis also. So with this, we have done further investigations. The creatine kinase was high with 1700. And since the patient's clinical features suggested dermatomyositis, we have done the EMG where it shows fibrillation potentials and positive sharp waves and short duration, low amplitude polyphasic motor unit potentials with early recruitment pattern, suggestive of myositis since creatine kinase also high. And then at that time, we have sent myositis antibody panel, and the patient was so ill where we couldn't proceed with muscle biopsy, and we were awaiting HRCT. At this point, patient being managed at HDO level with high flow nasal cannulae and empirical antibiotics, suspecting the working diagnosis being acute infective exacerbation of possible underlying ILD in the background of dermatomyositis. And so this is the summary up to now. So patient has had constitutional symptoms, proximal muscle symptoms, and lung involvement. And the examination findings suggestive of dermatomyositis and admitted with desaturation. Investigations also towards the same clinical diagnosis. So inpatient clinical course, it's actually fatal deterioration where patient on the third day of admission, patient went into impending respiratory failure, which requiring invasive ventilation and ICU care. And unfortunately, despite our efforts, patient passed away on the 5th day of admission. So after several weeks of the passed away of the patient, the family members came with the myositis panel, which cost about 75,000. Ultimately, anti-MDA5 antibody was positive, which confirms the diagnosis of anti-MDA5 positive dermatomyositis with possible rapidly progressive ILD. So musculoskeletal symptoms and distinctive dermatological features of dermatomyositis and rapidly progressive possible ILD with positive MDA5 antibody concluded the diagnosis. So now the case is open for the discussion for the expert panel.
Thank you for presenting that case. It's a very tragic case, but we now know MDA5 associated myositis. You know, at the time that she was in the ICU, she was near death. You know, that's the time for everything to happen. So, certainly in our center would be IV, pulse steroids, plus 2 more immunosuppressive therapies. You know, here it sounds like tuximab is an option, or ventilate's an option. In the US, they would be using IVIG and tacrolimus in such a patient. But yeah, a minimum of triple combination therapy.
I will explain that some patient even if I will vaccinate and cytoplasmide, the effects of ulcers, the patients are not responding passing away. And so I see the slide. So we had emphysema, and we tried that. So that time it was like we treated it better. I don't know. Very high water. So how about opacity? So usually we do screening for TB before opacity. So in this case, in this kind of patient, so it's like we have to treat early, and so I was seeing one patient. So patient after opacity, the patient recovering, but patient had tuberculosis.
The most important actually, even in Canada or UK, I'm sure that this patient could not have the MDA5 on time. Yeah, so that's why it's important. This patient from the beginning, please correct me if I'm wrong, is an MDA5 suspect. So you don't need MDA5 repeat. So this patient is MDA5 suspect. So the clinical scenario is MDA5. I'm not sure that Dr. Johnson is agreeing with me or not. but is a clinical suspect of MDA5. And this infection could have been not an infection at all. So this could have been the RPILD itself. So there, it's important actually that to consider procalcitonin maybe and use other parameters. And so these are common scenarios. Is actually most of the time that when a person is RPILD, they might have a subtle infection in the background or might not, but that should not kind of change our management at all. So most important take-home message that I'd like to give to the audience is actually, even in the UK where I work, maybe in Canada, that MDA5, we can't wait for the MDA5 results by the time. And also, we can't even wait for the EMGs actually, because this patient is, we can't, EMG also takes some appointment-based time system that it takes some time. But I don't think that EMG is required in this patient. Is from the beginning is MDA5 suspect. An infection could have been there or not, but I think that we could have kind of offered a lot of immune suppression in this patient, but still the outcome could have been the same. It has a very, very poor prognosis. But this so-called infection, just be careful because most of the patients in the ICUs with poorly resolving pneumonia, as we see, there's hardly an infection. Just, they are the RPI in this that we are seeing.
So usually we see the clinical feature like inverse bottoms, and if there are skin necrosis and other features, if that will be developed in RPI, problem is we can't start steroids because so the physicians also don't agree that because of thinking of infection.
Yeah, but I think with the time it will change.
She had short of the breath for about 6 months and it took us and showed this
So clinically, she fits a diagnosis of dermatomyositis, and while we were waiting the antibodies, she could have been a JO1 or any other antisymptoms. So I don't think that rapidly progressive ILD was a diagnosis we were thinking earlier on. I would have thought this was a dermatomyositis associated diagnosis. At that point, I would have started our usual immunosuppressive therapy, for moderate dose oral prednisone plus 1 or 2 of our other TMARs. It was only when she had that rapid decline and high oxygen requirements towards the end of the case, that's when we'd start to invoke the MDA5 associated. So yeah, I think she required just for the diagnosis of dermatomyositis is what she required.
Madam, this is the first encounter of tertiary care center for this patient. So patient being probably treated at the community with a general practitioner with low dose methotrexate and steroid. So might be the cause where patient has had the subtherapeutic control of the symptoms, where patient was still bearing up the symptoms.
Actually, I also want to mention, so now the respiratory physician we should agree now. So rather than injection, it was early days, so it was very difficult to convince them. But now, yeah.
Even now, treating the chest infection is not as simple as treating RAIU. And you can do the together. How many times we had the face of blood culture we positive? Like how the infection will hear us when the patient is getting hypoxic. People just they generally don't fear infections. They have to say that. Amila endorses this.
Yeah.
And we work here for how many years?
4 years.
Yes.
Can I ask? Time. Fast. Chasing for no place to go to. Now they're just coming back. Because before everything can act,
mentioned that. But when they mentioned ILD,
Be a lifesaver. At time frame that we don't have time.
by time that
So the ACR guidelines recommend against plasma exchange, but recommend for ILD.
Debates that if the cutting
But again, I mean, the level of evidence is very poor, isn't it? You don't have that. So I mean, it's very because basically the panel in the ACR. I mean, they have water regrets. So that means it is not in the guidelines. So they have water regrets.
I know, but
Yeah, but that doesn't mean that wheat is not indicated. So basically, it has a place, and I mean, it doesn't work in our country. The work could have been different.
yes, we don't have things, we tend to use
Yeah.
it, whatever is available. And it was the case of macular degeneration at Pittsburgh. So I faced a lot of questions. Why did you do this? Where was the
Yeah, no, I mean, that again, depending on the available resources, basically, I mean, that's simple as that. For example, I mean, our European and our American fellows, they have all the resources available, but once you have everything, we don't have anything, and also our clinicians are strongly suspect infection, but still you think that's a mild spectrum. Why don't you go for Plexo IEI? Because that's the only kind of safe option that when our other colleague is strong suspect infection, but still that can save a life. So I think there's a point there, and especially when the team is suspecting an infection and the other team is suspecting as a rapidly progressive ILD, they can't come to agreement. Plexo IEI, there's a quick place.
Here my experience on infection and rapid infection all in one go. I have to immunosuppress. How if I got a rapid immunosuppression and Sanachika, the lungs will white out. That infection they can control.
Yeah.
this damage that you get in vaginal lung when there is pulmonary hemorrhage. I mean, there was at 12 o'clock at night, whether this is a cell in there's a rock spot, whether this is cellular hemorrhage in the cell, these patients are naive, and whether this is vaginal lung. So, but we gave plasma exchange.
One question to ask from the kind of primary team on this, have done excellent, but I would like to know what is the availability of HRCT versus EMG in my centers. EMGs are kind of very difficult sometimes get appointments, but HRCTs are far more accessible.
So usually in patient was severely ill, that's why we haven't get done the HRCT, but the EMG, our Professor Ajira Veerasinghe, sir, anytime if you request for an urgent request at even at 12 midnight, he comes and do.
So great difficult kind of availability in EMG. In general in Sri Lanka, it's not like that. So EMG takes a lot of time to provide.
More patients needed.
Yeah.
Very nice case, and thank you very much.
Okay. Thank you very much, madam. I just want to acknowledge Dr. Chaturika Damdenia, the consultant rheumatologist and the senior lecturer in Department of Medicine, University of Peradeniya, and the Kandy Society of Medicine and College of Specialists in Rheumatology and Rehabilitation, Sri Lanka, and also the Pulmonologist, College of Pulmonology, and the management team, whole team at Peradeniya, and the patient and especially the family. Thank you very much.